Assalamu alaikum to all. So today we will do the environmental emergencies, dermatology, and I will also tell about the DVLA restrictions and a small topic about pain in children and pain in adults. So first we will cover, I will only tell the important thing about the environmental emergencies and dermatology. You can revise it from the MRCEM success, okay? And you can attempt their MCQ, that's sufficient. Okay, in environmental emergencies, hypothermia, that's very important. Okay, hypothermia mean it's classified into three: mild, moderate, and severe. When the temperature is below 28, that is called severe hypothermia. Moderate is between 28 to 32, and mild is 32 to 35. 4, you can say below, because below 35, that is hypothermia. So 30 to 34, that is mild hypothermia. So there's this other staging, that is Swiss staging, that is stage 1, stage 2, 3, 4, 5. Mild, moderate, severe, that leads to cardiac arrest, and other can lead to death. Mild hypothermia, patient will be conscious, shivering, but the core temperature will be 32 to 34. And moderate hypothermia, impaired consciousness, patient will be, there will be impaired consciousness, in GCS will be low, but without shivering. Always remember that the core temperature is 28 to 34. And in severe hypothermia, patient can be unconscious, vital signs are present, but core temperature is between 24 to 28. Stage 5, patient can went into cardiac arrest. So that's very important. After how low the temperature is, then patient can go into cardiac arrest. That is less than 24. Stage 5, patient that can lead to the death due to irreversible hypothermia. So it's also important that when the hypothermia becomes the irreversible, that is below the 13.7 temperature. Okay. In the option, they can give it like that which option, which of the statement is correct. So that's why you must remember that at which temperature cardiac arrest can occur, at which temperature that can occur, and reversible hypothermia can. So that's why these points are important. Other, we will check the core temperature with the low reading thermometer that can be checked in the tympanic, esophageal. So that's how we can check the temperature. That can also check tympanic, rectal, esophageal. On ECG, but these are the least likely changes we will see, and we will go for it. That there can be Osborne and J waves on the ECG. And the most common arrhythmias are bradycardia and AFib. Okay, so hypothermia in children, that's very common, and that the children will go into bradycardia and AFib. That's very common. So there can be other causes. Sepsis can also lead to the hypothermia, and endocrine causes, which must rule out other causes. Okay. Okay. So if patient is in a cardiac arrest, they went into cardiac arrest, and temperature is hypothermia, because we in 4H40 there hypothermia. So what the changes we have already discussed many times. There before 30 till 29, we can't give any drugs. Okay, we will not give any drugs, neither adrenaline. Okay, and but we can give we can defibrillate if patient is in a cardiac arrest up to 3 attempts. We will defibrillate, then resume the CPR, and then we can again, if temperature is less than 30, mean 28, 27, 29. So then we can repeat. So up to 3 shocks we can repeat. The other thing, when we will give the adrenaline, that we will give from 30 degree to 34. Okay, when the temperature is 35, then we will follow the normal rhythm. But as the hypothermia is below 35, mean 34, 33, 32. But 30 to 34, we will give the adrenaline by increasing the administration interval. Always remember that is interval, mean we will increase the time. If we were giving after 4 minutes, then we will give now after 8 minutes. So that's how we will increase or double the interval. That's the difference in ALS algorithm. So there can be passive rewarming, active rewarming, and core rewarming. Passive rewarming, we will wrap the patient in warm blankets, and active warming, we can give the heat bags, heat blankets, heater, we can use the heater, and we can also start the warm fluids. That's the warm warming. Nowadays, there are hot air blankets that are used commonly in the emergency department. Then the core rewarming, airway warming, heated, humidified, oxygen provides some different heat and reduces the air loss. So we can warm the fluid up to 38, and then we can give it. Then next is the frostbite and non-freezing cold injuries. Frost, first degree frostbite, that is the injury to the skin just because of cold. Okay, that can injure the skin, can cause the hyperemia, necrosis. So that's very important. Like it will injure the skin like the burn. So as in burn, there are degrees of burn. So in that same case with the frostbite, first degree frostbite, there will be hyperemia, edema are present, with there will be no skin necrosis. In second degree, there will be vesicle formation, and there will be partial thickness skin necrosis. These points are very important. In the third degree, that will be full thickness subcutaneous tissue that can be commonly associated with hemorrhagic vesicle formation. Fourth degree frostbite, in which the full thickness skin occurs, including muscle and bone. So that's not a lot important, but you must go through it. That was freezing. Then the non-freezing cold injury, that the trench foot or cold immersion foot. Okay, next is the management. Okay, if patient with the frostbite, as that happened with the cold, so if patient has developed a hypothermia, so we will delete it because that can be life threatening. We will not rewarm if there is risk of refreezing. That is very important. So if the frostbite has occurred, we can rewarm. Okay, rewarm, we can place our hands, legs in the warm water, not the cold ice water. Okay, so we can put it. So as the patient has a frostbite, and if we will do the excessive rewarming and we will give the excessive heat, so that can lead to the perfusion syndrome, acidosis, hyperkalemia, and local swelling. That's the rest management. Sorry, that hypothermia, arrest, cardiac arrest management we have already discussed. Now come the drowning. It's very important. The question have been asked many times. Okay. So in the drowning, most of the common system that would be affected, what would be that in drowning? What would be the common system that would be affected? So that the respiratory, okay, respiratory system will be compromised. So that's why, because there is a chances of expiration, and that can also cause atelectasis, ARDS. So that can respiratory system will be most commonly affected in the drowning. So there's no difference where the person got the drowning. The predisposing factor is very important. Most common predisposing factor in adult is alcohol, and then the prognostic factor. It depends on the submersion that for how long the patient remained in the submersion. So if it is less than 10 minutes, that is a good prognostic factor that the patient will recover soon. And if it went to cardiac arrest, that can also uh, loss can be achieved. If it is more than 25 minutes, that is a poor prognostic factor. And this question have been asked many times previously.
Hang in there, not just give your wickets away. 7 in the first, 6 in the second.
Keep mute. Cardiac arrest management, that there is also a difference in the cardiac arrest management of the drowning. As I have told you that, what is the most common cause of cardiac arrest in children? From the 4H40, what is the most common cause? In children.
Hypoxia?
Yeah, hypoxia. So that's related to respiratory system. So how we start the PEDS ALS? How will we start it? What we give? What we give if child has went into cardiac rescue breath? So because the hypoxia is the most common cause in the adult, cardiac is the most common cause that can lead to the cardiac. So compressions are most important in adults, and ventilation is most important in children. So in the drowning, As I have told you that respiratory system will be most likely compromised. So that's why there is the changes when patient has went into cardiac arrest. We will give the 5 rescue breaths or ventilation using the inspired oxygen. So that's very important. Okay, you must remember it. That can be asked. So after the rescue breath, we will reassess and then we will call for help. We will start 30 into 2. The other thing that as the drowning, we must measure the temperature. If patient is in a hypothermia, so our management for cardiac arrest will change as per temperature. And also intubation, early intubation is very important in the management of drowning. And we can also shift patient went into cardiac arrest. We can also shift to the mechanical compression. So hypothermic we have discussed, then we should first treat the hypothermia. So you can see that here it is written that most victims of drowning are at risk of developing acute respiratory distress syndrome. And pneumonia is common after drowning. So that's you can see the respiratory system is the most effective system after drowning. As there is no role of antibiotic, but we can start prophylactic antibiotic if you are think patient take expecting as a prophylactic to the pneumonia. So final. So as the patient come with the drowning, hypothermia, every patient, we will follow the ABCD protocol. Airway, breathing, circulation, D, then E. And so that's ABCD. Okay, we will do the ABCD. So when we will read this E, we can see for the spinal injury. Okay, that's very important. We can do the log roll and drowning. So ABCD protocol is very important. Whoever the patient coming to the emergency department. So pneumonia can be the most common. So that's why we are starting the prophylactic antibiotic. If patients after drowning are asymptomatic and there is no respiratory compromise, chest saturation, chest X-ray, ABGs are normal, then after 6 hour observation, we can discharge home. That's also very important point. After 6 hour observation, we can discharge home. Malignant hypothermia, we discussed about the drowning. Hypothermia, that was low temperature. No, it's the high temperature. Okay, hypothermia. When we will call it malignant hypothermia, when the temperature is above 40. So malignant hypothermia can happen due to drugs. The most common drug is succinylcholine. We must remember about it. So how will we treat the treatment? Mainstay of treatment is dantrolene. So we must give the dantrolene up to 72 hours. We will also do the supportive treatment that can be cooling, active cooling, passive cooling. That's very important. And always remember that malignant hyperthermia can be genetic. So we should send for the malignant hyperthermia center where they will investigate, rule out other causes, and also will do the genetic counseling. That's very important. Why we are checking the creatinine kinase?
Because of muscle breakdown and release rhabdomyolysis
Yeah,
and
rhabdomyolysis. Good.
is occurring, potassium is coming out.
And other is the neuroleptic malignant syndrome. Okay. Neuroleptic malignant syndrome and the serotonin syndrome. These are very important and that will come in the exam and that will confuse you. Okay. So you must remember about it. Another thing in the hypothermia, always remember that if we have started the resuscitation, we should prolong it. Okay. More than 25 minutes. That's very important. So neuroleptic malignant syndrome is a complication of which drugs?
Antipsychotics.
Yeah. Okay. So that is a complication of antipsychotic drugs. Either it can be the withdrawal uh, due to the dopamine agonist. Okay. Decreased dopamine activity that will lead to the decreased dopamine activity. So that can lead to the neuroleptic malignant syndrome. So how will we see that it's that the altered mental state? There will be muscle rigidity. What type of muscle rigidity will be in neuro that will differentiate from the serotonin syndrome? Okay, we will discuss serotonin syndrome. How will we differentiate? So ultimately that will be common in both. Okay, and muscle rigidity, that would be which type of muscle rigidity? Lead pipe. Good, lead pipe. Lead pipe. Okay. And the autonomic instability mean there can be hypotension, tachycardia. So that's same. Then hyperthermia. So other thing that in the neuroleptic, that would be lead pipe muscle rigidity. Okay. In the serotonin syndrome, that would be clonus. Most likely, what type of clonus there would be? That you will differentiate it from neuroleptic. So in serotonin, that would be ocular muscle clonus. So that's very important. In the neuroleptic, there will be normal pupils, but when we will look for, okay, we okay, how will we? This is also hyperthermia. how will we differentiate that it is not of malignant hyperthermia? Like in, we have discussed that it's a malignant hyperthermia here. Temperature is high, okay? In serotonin, there will be also high temperature. Yeah, that's the drug history that will lead to another greater than 40. And how will you differentiate the malignant hyperthermia from the heat stroke? That it's the heat stroke. That how will you differentiate? In serotonin, or although it's lichen 38 or above, but it can be more than 40. That's also in the heat stroke. So temperature is 42 and patient is found in the street. You don't know that it happened due to heat stroke or that. In the heat stroke, there will be no sweating, loss of sweating, okay? Loss of sweating. But in neuroleptic or serotonin, there will be diaphoresis, okay? Always remember it. Yeah, good. There will be no sweating, but in this, there will be diaphoresis. We will discuss about the heat stroke. Okay, I hope you have got that. How will we differentiate between the neuroleptic serotonin syndrome? That's very important. So that's serotonin also, it happen within hours, okay, and that can happen anytime after starting the medications, okay. So first of all, treatment in both is that we will stop the medication. We can give the bromocriptine. Serotonin syndrome that we have discussed, excess use of serotonin agonism receptors, so that the drugs we use it that can lead to the serotonin syndrome, fluoxetine, pethidine, tramadol, cetropiram. So in moderate intestinal cord temperature is not common. Physical examination. So there will be dilated pupils. In neuroleptic, how was the pupils?
Normal.
Normal. Good. So in there will be diaphoresis. So that's in same. Clonus, that's the spontaneous and ocular. Okay. And in that, what type of rigidity was that? Lead pipe rigidity. Okay. That's also that is hypertonicity and their hyperreflexia. So these are the differentiation you must know about it. That are the common question in the exam. So management, we will control agitation. We can give the 5-H3 antagonist. That is ondansetron. Okay. And that we have discussed that it will, as serotonin that happen within hours, so it will also resolve within hours. So 24 hours, that's also important. So we have to give the supportive treatment, intravenous correction of fluids. If patient is agitated, we can also use the benzodiazepine. If there is severe dose, that is the antidote we can use. Cyproheptadine, okay? That we use in very severe cases and rarely used. Doctor. Okay, so that's the difference. We have discussed medication type, dopamine antagonist, withdrawal of dopamine agonist, okay? Dopamine antagonist or withdrawal of dopamine agonist, and that the serotonin agonist, excessive use of serotonin agonist. That is onset, serotonin will be rapid within 24 hours, and neuroleptic that can be lead to days, okay? Recovery will be also prolonged as it's happening with days, so its recovery will be prolonged. But serotonin that's happening rapid, its recovery is also rapid when we will give the medication. So in neuroleptic, that the lead pipe, and in serotonin that is ocular clonus, spontaneous clonus. That's what, and in serotonin hyperreflexia and that hyperreflexia. So diving emergencies, that's very important. Barotrauma. So when the barotrauma will happen, so barotrauma most likely happen when the diver is near the surface, okay? Mean end of when its diving is ending. So that time barotrauma can happen. Why it's happen? Because of the pressure. So as the pressure will decrease, okay, so there will be increase in volume of gases. So that can lead to the damage to the structure, like which are having the gases or air filled structure, like lungs. It can lead to the damage to the lungs. There in the air is present in the sinuses, that is making our skull light. So that can also lead to the trauma to the sinuses and the other that can be intestinal. So it is skin barotrauma, and mediastinal emphysema is a common event present with increased hoarseness, neck swelling, retrosternal chest discomfort. Pneumothorax, that can be complication, dental pain. So that's the barotrauma that can happen. Other is the decompression illness. So that first is when the desired nitrogen in blood and tissue is not expelled at a sufficient rate to prevent the bubble formation. Secondly, occur when the air bubble are released into circulation because of pulmonary barotrauma. So that can lead to the decompression illness. So we have to do the recompression. We can give the high flow oxygen, analgesic, sedative, but always remember the Entonox we will not give it, okay? Then the heat exhaustion, heat stroke. I already told you about it. In the heat stroke, if that happens in the labor and in the old age people, in the children who directly went into the sunlight, and that can lead to the heat stroke. So that's why I always advise them to cover their place, take a shower with the time being, take a plenty of drinking of water. So when the temperature is above 40, that can lead to the heat stroke. And always remember in which there will be headache, okay, and there will be loss of sweating, because thermoregulation, there is a body with thermoregulation. There is a high temperature, body is stimulated to cool it. So at some point there will be no thermoregulation, that will lead to the heat stroke, and that's why there will be no sweating, as sweating is a part of thermoregulation. So very important that in heat stroke there will be no sweating. Patient will feel headache, dizziness, and they can also lose consciousness. So that's why first we have to move the patient to the area where there is either we can place underwater. Uh, Submersion is not practical, but we can use it. So we should not give the antipyretic, that there is no role of paracetamol, dantrolene in heat stroke. That's very important. Evaporative cooling is most effective when the temperature is less than 39. We should not do the active cooling. Okay, so other electrical injuries that's are common, and electrical injuries that can lead to the cardiac and respiratory arrest. If electric have passed, there can be 2 or more entry exits. That's not important that we go further, but that's the wound we have to treat. The most important thing in the electrical equation is the arrhythmias that can lead to the cardiac arrest. So we have to do it, and if that happens in the pregnant woman, that can be also risk to the fetus. We will get the option gynae advice, and we will also do the CTG to ultrasound to check the fetus and mother, both are at risk. So cataracts are also common after the electrical injuries. So how will we manage? That's very important. We have to turn off the electricity. We have to do the scene safety. We have to remove the patient from that area and place it at the safe area, call the help. The most important thing that if patient is vitally stable, everything is okay, and there was a minor electrical shock, but we will do the ECG. The most important thing that we must do is the ECG. Okay, without ECG, we will not discharge the patient. That's very important. And we will also do the urine complete examination to check that there is any myoglobinuria, and because that can lead to the rhabdomyolysis. Creatinine, electrolytes, that we can check if the patient has any issue ECG with ECG. But the most important is ECG. As it can lead to the fluid loss and hypovolemia, we can give the fluid. If there are high voltage injury, that can lead to the burn, tissue damage, so we can go for the fasciotomy. So when we will discharge, when we will admit, that's very important. Asymptomatic patient with domestic ML, if they have normal ECG, we will do the ECG. If ECG is normal, there are no arrhythmias, no other problems, no obvious wounds, then we can discharge, no myoglobinuria. So children who have electric shock, electric injury, we must keep observation, we must admit, and after that, the child PEDS team can decide when to discharge. That's the radiation illness from the X-rays, any radiation, any type of radiation. So in this, the lymphocyte co-analysis chromosome, that is important. Lymphocyte can fall as 0 at 1, 0.
Our collaboration has been removed that the treated patient has irradiated but uncontaminated.
Okay, so I have only mentioned the important points. Okay, you can go through the MRCEM success MCQ that are sufficient to do this, and because you will get only maximum two MCQs from. Now I will also discuss DVLA. Okay, so anyone have read it, this chart? So that's very important chart. I will share with you all because one MCQ is must from here. So they usually they don't ask about the bus. Okay, I have not seen it. You must know about it. So what's important? They will ask about the hypoglycemia. Okay. If patient was on oral medication, okay, oral medication. So you can see no change unless debilitating hypo, no change. If patient was on insulin and then patient has hypoglycemia, then DVLA will give 1 or 2 3 lessons, then review. If patient is on insulin, okay, patient is using insulin, so DVLA will give the lessons and will review 1 2 3 year lessons, then review. So if it is on temporary, then no need to notify the DVLA. If patient is on oral medications, so there will be no change unless the patient went into hypoglycemia, any such symptom happen. The patient is having severe hypoglycemia, means patient has hypoglycemia and patient could not take any oral medication to treat his, and he had to give any IM or IV thing. So that's mean third party assistant. So that's why if get to the one episode, lessons revoked, reapply after 3 months. Okay. I will also share the 50 pages notes with you, but that's the table. Okay, so most of the common that have been asked is about the TIA. Okay, TIA. If it is a single episode of TIA, so must not drive for 1 month. Don't have to notify the DVLA. If multiple episodes of TIA, must not drive for 3 months. Always remember. If there is stroke, must not drive for 1 month, then need to inform the DVLA. So you will write and inform that you must notify, you will put your notes that you must notify the DVLA. So 1 episode, 1 month, more than 1, 3 months, okay? And stroke, must not drive, have to notify. That's very important. Then the syncope. Unexplained syncope. You don't know the cause of syncope. So must not drive for 6 months and then you have to review it. Okay. Cardiovascular syncope, and there can the cause you have come to know that it was cardiovascular, must not drive for 6 months and then reviewed. So that's very important. That's also same, must not drive for 6 months, must not drive for 6 months, then reviewed. Vasovagal syncope, that's also sitting on, if syncope on sitting can drive. If avoidable trigger that would not occur while driving, otherwise need annual risk 20%. Other thing, seizures. So that's also one episode, multiple, non-epileptic. So these are very important. If it is a non-epileptic seizure, must not drive for 1 year or 12 months. First unprovoked seizures, must not drive for 6 months. Provoked seizure must not drive for 6 months. Dissociative seizure must not drive for 3 months. So this chart is very important. You must go through it. I will also share a detailed chart for it. So other important thing that is angina, must not having angina symptoms. Acute coronary syndrome must not drive for 4 weeks. So in the exam, they can give that patient has a STEMI, ECI was done, or you are going to discharge. So what advice you must give to the patient? That's also important in the OSCE when patient have come with these symptoms and you have done, you have taken the history and then you have moved the resuscitation area, you have done the PCI, and then you are going to discharge the patient and any advice, then you will say that you must not drive for 4 weeks. That's very important. That's without PCI. With PCI, okay, successful PCI, must not drive for 1 week. Cabbage, that's also 4 weeks, okay. So remember it. If PCI done, then 1 week. PCI not done, successful PCI not done, then 4 weeks. So this was about DVLA, pain, restriction. So the children, you must that the non-pharmacological treatment. So for the children, we have to psychological strategies, child-friendly environment, distract the child. If anything happens, child is crying, distract it with anything like you can distract with anything. Most of the time, if you have seen that child is crying, you start playing anything in front of it on the screen. That will be distraction and child will stop. And you can also do the dressing, immobilization, that is the non-pharmacological. Okay, first you will do it, then on the basis of severity. So if it is a mild, we can give the paracetamol or brufen, any one of it. Okay, so that's the 20 mg loading and then 50 mg 6 hourly, and then ibuprofen, that is 10 mg, that is 8 hourly TDS. Okay, and moderate, then you can add both. Okay, paracetamol plus diclofenac. Either you can give the diclofenac and oral codeine, but always remember that we give it above 12 years of age. Okay, in the primary, if you have read it, that is contraindicated in children below 12 years. Morphine we don't use. Always remember that in the children, they will tell their patient having a burn and crying, and what have you do? You will give the intranasal diam. That's very important. And the procedural sedation, we have discussed that Antonox that can be given by the nurse. Nurse can give it, but for the other sedation and things like that, so that we that is given by doctors or the expert. So in the exam, most of the time they will ask about the intranasal diamorphine. Either they will ask about the non-pharmacological. That's the common question that have been asked previously many times. So moderate and severe pain, we must give the painkiller within 20 minutes. Always remember, okay? So we will reevaluate after 60 minutes. That you must remember that within how long we will give the painkiller and after how long we will review it. So we will give it within 20 minutes and after 60 minutes we will reevaluate. Okay, so other thing that is in adults. Okay, in adults, score 0 initial assessment, we should assess every patient with coming with the pain within 15 minutes and reevaluate if there is no pain after 16 minutes, mild after 16 minutes, for moderate after 30, within 30 minutes we will reevaluate. A severe, 15 minutes of level we will give the painkiller, after 15 minutes we will reevaluate. So in the emergency department, pain is the first most important thing. You have to relieve it. You have to make the patient pain free. That's the very important thing in the emergency department. If you have relieved the pain, patient will feel better. Okay. So that's why it's very important. You have to assess the patient within 15 minutes. Every patient coming with the pain. Okay, so the other things are same, non-pharmacological, pharmacological, mild pain, that we will give the same oral paracetamol or oral NSAIDs, like in children. We will using there we can give any NSAIDs, Decloron, anything. Moderate pain, mild pain plus oral, we can give the NSAID if already not given, codeine, and for IV opiates, rectal NSAIDs supplemented. So for the renal colic, that's difference. And what's that? I think I have written it about many times. I have told. For renal colic, what is the first line treatment? First line painkiller. NSAID. Then no, not the ketorolac. Dr. Naeem, I have told you that don't ever follow the Pakistani guideline. Okay. Always follow the exam guideline. That are RCAM or NICE guideline. No other. So first of all, we will give the NSAIDs for the renal colic. Okay. And then if that's not effective, then what we will give? Second line. No, not opioids, not opioids. Once I had a renal colic and after that I canceled my lecture and I sent a detailed message on it. Investigation choice, everything I told. Looking for exam. That's also important in OSCE, okay? Paracetamol, IV paracetamol, second line. Then third line for renal colic. We are talking about renal colic. So we give that always Decloron, oral Decloron, okay? oral. We will give the oral. That can be rectal, oral, IM dicloron. So NSAID, that can be anywhere. And then IV paracetamol. Then we will go for the opioids. That's the third line for the renal colic. Okay, what's the investigation of choice? Although we will do it in the urology, we will have a next session on nephrology and urology in coming weeks. Surgical emergencies and urology, we will do it combined. So what's the investigation of choice? Hurry up, then we will do dermatology in half an hour, then we will finish. CTKUV, not CT abdomen, okay? CTKUV. If you are going for CT abdomen, always go for the IV contrast, okay? There's no role of ultrasound KUV. That's not effective. If patient is coming with the ACS and patient is contraindicated to morphine, patient can't use it. We can't give the morphine and not available in your setup. What you will give? In Pakistan, you know that we don't use the morphine, okay? So we can give the other opioids, okay? We can give other opioids because it is severe pain. Okay, now we will have a dermatology overview. You can also go through the MRCEM success. MCQs you can attempt for the environmental emergencies, pain, and then the dermatology. So first of all, empirical, always remember that it is most common, and there is the file. The file, and that is the file. I think you can see. I have covered all. Yeah, you can see. So you can take the photo of that. These condition, you must go through the images on the Google, okay? Childhood exanthemas, drug reaction, eczema, erythroderma. These are also related to children. Infection of skin and soft tissues, necrotizing fasciitis, pressure ulcers, rash, including hands, swollen purpura. That's very common, okay? That have been asked many times. Steven Johnson, toxic epidermal necrolysis, urticaria. So these are the common in the children. So that's about the children. You must also know about the adult. Impetigo. So that's so we will keep in isolation until the lesion crusted, either 48-hour past treatment started. Okay. So we will keep because it we will give the localized bolus, localized, and we will give the topical fusidic acid if it is a localized hydrogen peroxide. If it is widespread bolus like this, we will give oral medication. So for step 4, yes, I told that we will give fluoxetine, always fluoxetine. Okay, so these are complicated bolus. We will give the oral fluoxetine. So that's first we were giving topical, then topical oral fluoxetine, then we go for oral fluoxetine. Then the erythrocyte multiform. There you can see that there are the clear margins inside. So these are erythema multiforme, central pale, and target lesion. These are called. So most common, these are herpes simplex. That can be also mycoplasma. Target lesion, these are less than 10%. Steven-Johnson syndrome, that is 10 to 30% skin involvement in Steven-Johnson. So that's the difference between the toxic epidermal Steven-Johnson. So that would be consist of both painful pink to dark red spots. Okay. That will involve the skin, lips, mouth, and eyes. I have seen 2 patients of Steven-Johnson in ICU. So this condition like mouth, redness, bitter regions. So you must go through it. Then the toxic epidermal necrolysis, there will be 30% skin involvement. And we will do the Nikolsky sign, that would be positive in 10 toxic epidermal necrolysis. That's very important. And with the layer, the early law of. So scan biopsy, that is the definitive investigation for 10. And we must start the prophylactic anticoagulation of IV immunoglobulin. That's very important. HS Henderson purpura, that's very common question in that the patient will be having grayish abdominal pain, arthritis, glomerulonephritis, skin, joints, kidney, and GIT. Okay, so lower abdominal pain, arthritis, glomerulonephritis, rash, very common question. Respiratory tract infection, abdominal pain, joint pain. What's the other investigation? That's the urine analysis. Okay, that's very important. You must know that. So age is between 3 to 5 years. Benching blood pressure is chicken pox. So I have told you should send to the school or not. That's very important. And that's about Mavia. You must remember Mavia will not go for 5 days. Okay. Measles and rubella will not go for 4 days. Okay. Measles and rubella, MERUB. Okay. So that's the or Mavia, MUVEA. So that's his mumps and varicella zoster, that will not go for 5 days. I'm not mixing, I will, that's the 5 days. Okay. Treatment, cyclovir, 800 mg 5 times a day. If complications have happened, then we will give it. In the immunocompromised patient, we will give it. And I also sent and told you about the chicken pox and pregnant women. That's also very important for SB exam and OSCE exam. You must go through it. Then the hundred Okay, so that's the eczema on left side. Mild, we will give only amyloid, mean what we call it, common language. Level is 1%. So that's the dose, okay. From 0.05 to 1% we will give in the severe cases. Infected, we will also give the oral fluoxetine because Staph aureus is the most common cause that would cause the infection. So there can be also the superadded infection on the eczema with herpes simplex. That's called eczema hepticum. So if the age is less than 2 years, we will urgent refer to the peds department. We will start the oral. Shingles, that's very important. In shingle, we must start the antiviral therapy in 72 hours. That also the 5 times for 7 days. Always remember that's the common. And which area will be involved? Which nerve? Active and in the shingles. Yeah, trigeminal. So their trigeminal tract will be affected. So okay, so other thing, erythema infectiosum, that's called fifth disease. You can see caused by parvovirus B19, slap cheek syndrome. So that's also important. Cellulitis is spilus, that's you can see as spilus in cellulitis. Spilus that the upper dermis and lymphatics, cellulitis on the deeper dermis and subcutaneous fat. Just as there will be raised edges, cellulitis, there will be in this, you can't differentiate the edges, okay? And that's cause Elon classification of cellulitis, no systemic toxicity. Then we will give oral treatment, systemic, unwell, control morbidity. Then we will give the home treatment with all IV medication. We will decide if there is systemic, we will admit an IV antibiotics. If there is hypotension, any signs of sepsis, then we will admit in the ICU. That the scarlet fever, streptococcus notifiable disease, penicillin, we will keep in isolation. It can resolve in 48 hours, for 24 hours after starting the antibiotics. So scarlet fever, rubella. So you must know the difference between the rubella and measles. So it's very complicated and vaccine. So you must know about it. In pregnant women, it can cause a newborn eye defects and rubella syndrome. That's very neural tube defects. So this is from the derma. So I will share this file with you. You must go through the MCQs of SLO from MRCS PDF. That would be enough for you. You must go through all of the diseases, common diseases, the diagram. So this is very important. I hope you enjoyed, and that was the end of session. Any questions you can ask? There we finish.